Okay, everybody, now this is the last PowerPoint slide that I have for this week. I can make more if you want me to and narrate them. You just have to tell me what topics you want to cover better, and I can make this for you. So for this PowerPoint, we're going to be talking about atrial dysrhythmias. These include premature atrial contractions, which we call PACs, atrial tachycardia or SVT, atrial flutter, and atrial fibrillation. So PACs, like I said, they're premature atrial contractions, which is an early beat that originates from an ectopic site in the atria. So the early beat is characterized as an abnormal P wave with a normal QRS that's then followed by a pause. So you'll just see that you have a patient in, let's say, a normal sinus rhythm, and they'll have an abnormal P wave or an early P wave, and that would be characterized as a PAC. So for criteria, this is an irregular rhythm because of the PACs. So if you have an irregular P wave beat, it'll initiate an irregular rhythm. So the P waves are early and abnormal in size. The PR interval may be normal, but it differs from the underlying rhythm. So like I said before, you might have a patient with a normal sinus rhythm, and then they'll have an early P wave beat, which would then differ your PR interval because of that early beat. Usually with these, the QRS duration is normal because the PAC has really nothing to do with your QRS. So some causes of PACs include anxiety, fatigue, caffeine, which if you ever feel like you're having a palpitation, it may be that you're having a PAC. I know being in school and working, it causes, fatigue and anxiety. So that might be a cause of a palpitation that you feel that you have. Heart failure is also a cause, myocardial infarction, electrolyte imbalances, especially with your potassium level. With these, they're usually benign and no treatments necessary. But if you have 3 or more consecutive PACs, that can put you at a risk for going into A-flutter and AFib, just as a side note. Okay, now we're going to be talking about atrial tachycardia and supraventricular tachycardia, also known as SVT. So this is a generic term for any tachyarrhythmia that occurs when there is no P wave detected, and it originates at the site above the ventricle. So with VTAC, we can say that the ventricle is quivering more. With atrial tach and SVT, it's above the ventricle, so it's somewhere within the atria, which is why we call it atrial, and then supraventricular, meaning above the ventricle. So for atrial tach and SVT criteria, like I said, it originates in the atria from an ectopic site with a rate of 160 to 250 beats per minute. This rhythm is regular. Your P waves are abnormal, and they can even be buried into the T wave. In the next slide, I'm going to show you a strip, like a small strip that I have of SVT, and you can see that there's no differentiation between your P wave and your T wave. They're combined, and you can't differentiate between the two. Your PR interval is hard to measure because the P wave is usually buried into the T wave, but your QRS is normal. So like I said here, you see you have a normal QRS like we talked about, and then right here, there's no differentiation between the P wave and the T wave. So this is going to be a fast rhythm, and you're not going to be able to identify the P wave or the T wave because they're combined. Like we talked about in the last PowerPoint, the T wave is ventricular repolarization. So that's the end of the beat, and that's when your ventricle is starting to rest before it fills again. So with that, you would usually have your T wave right about here, and then your new P wave. Well, it's just one wave, which makes it hard to identify a PR interval, a T wave or a P wave, but your QRS is normal. Then obviously you can see that it's a pretty fast rhythm by determining your R to R. Okay, some causes of AT and SVT. Abnormal conduction pathway, which we talked a little bit about. valvular problems, coronary artery disease, myocardial infarction, and in healthy individuals, you can see SVT occurring with stress, alcohol intake, and then caffeine intake. Another side note to think about is high altitudes also can cause patients to have atrial tachycardia and SVT. A lot of people in Colorado, because of the high altitude, have SVT. And then I actually had some friends that went to Peru last year, and they were climbing through the mountains, which obviously is a high altitude, and they both ended up with SVT. So they both had heart rates near 200, which was caused by the high altitude. Signs and symptoms of tachycardia, atrial tachycardia, and SVT, that includes dizziness, palpitations. You could have a syncopal episode, and that is usually related to any hemodynamic instability that you have. Decreased cardiac output is something that you could see if your patient's heart rate is extremely fast. And then something else to note is that the ventricles are unable to fully fill during diastole because the heart is beating so fast. So the higher your heart rate, the lower your cardiac output would be, because your ventricles are unable to fully fill during diastole, which then creates hemodynamic instability. Treatments for atrial tach and SVT include controlling the ventricular rate and then returning them to a normal sinus rhythm. Vagal maneuvers, which if you have a patient in SVT and they're maintaining a pulse, they're maintaining an adequate level of consciousness, some things that you might ask them to do are: 1, pretend like you're pushing out a baby; 2, pretending you're having a bowel movement; and 3, you can give them a straw and try to blow into that straw as hard as they can. Sometimes that will help the patient increase their vagal stimulus, and that way they can break out of that rhythm without any kind of medication or shocking. If your patient is unstable and they have SVT and those vagal maneuvers aren't working, you can always cardiovert them, meaning you put on the defibrillator pads, and instead of defibrillating the patient, you sync up the machine to their R to R, and that way you can cardiovert them out of that rhythm. A drug that you can also give is adenosine. So you'll start with 6 milligrams and then you'll go up to 12 milligrams. You can give this in 2 doses. Adenosine, what it does is it stops your heart. So you'll see your patient has a heart rate of, let's say, 240. They're in SVT. You give them 6 milligrams of adenosine very quickly with a rapid flush, and you'll see for 4 to 5 seconds on the monitor that they don't have a heart rate. This is an expected finding. It's not something that you'll want to start CPR for. The whole point of adenosine is that it starts your heart to restart it at a normal rhythm. And we'll talk more about that in clinical. Okay, now we're going to get into atrial flutter criteria. So atrial flutter is caused by the AV node failing to allow conduction of all impulses to the ventricles. So we talked about how the chief pacemaker of the heart is in your SA node, and then it goes from your right to your left side of your heart at the uppers and the atrium, and then it goes down to your AV node. So the AV node is not allowing all the conduction impulses to go to the ventricles. It's staying up in the top chambers of the heart. So you're going to see flutter waves in a sawtooth pattern. Your atrial rate will be between 250 and 400 beats per minute. Though something to think about is that the atrial rate and the rhythm is regular. So the last bullet point that I have here is the ratios of the P waves to the QRSs. So you might have a 2-to-1 ratio, meaning you have 2 P waves for every QRS. You could have 3 P waves to every QRS, and you could have 4 P waves to every QRS. And I think it's on the next slide, I have a picture of a flutter, the rhythm. But I'm sure you guys have seen this. I'm sure this is obviously not new. This is just kind of a basic overview. So for this particular patient, this is, like I said, atrial flutter. Their ratio for P waves to QRS, you're going to see 1, 2, 3 P waves, for 1 QRS. So they're in a 3-to-1 A-flutter ratio. Atrial flutter causes include valve disease, hyperthyroidism, hypertension, myocardial infarction, coronary artery disease, and then alcoholic holiday heart syndrome. So what this is if you have a patient who has consumed an excessive amount of alcohol, you can see that they may have a rhythm that's atrial flutter based on their alcoholic intake or their alcohol intake. They don't have any other known causes or disease processes associated to them other than the excessive alcohol intake. Okay, last rhythm we're going to talk about is atrial fibrillation. So the criteria for this is that in AFib you see no P waves, which means that if you don't have a P wave, you cannot measure a PR interval because the PR is the P wave to the R. If you don't have a P wave, you can't measure a PR. The QRS is usually normal, and you can either be in controlled AFib, meaning that your heart rate is less than 100, or uncontrolled AFib, meaning that you're in AFib RVR, which is a rapid ventricular response. So those patients have a heart rate greater than 100 to 150 beats per minute. What AFib is a disorganized electrical activity, so there's no effective atrial contraction. That's why when we tell patients who are in AFib that instead of contracting, your atria are quivering. Because the patients in AFib, it's also impossible to measure their atrial rate because they don't have any P waves. There's really no effective atrial contraction. Here you can see this is a rhythm of AFib, and you can see here there's no discernible P wave, and your R to R's are irregular. So those are the two biggest criteria for measuring or determining if your patient's in AFib. One, do they have a P wave? If no, then you look at your R to R. If your R to R is irregular, you're going to have a patient in AFib. Signs and symptoms of AFib include hypotension, decreased urine output, shortness of breath, fatigue, palpitations, and then your patient in AFib is always at risk for stroke if your patient is not already anticoagulated. I think I touched upon this in clinical. I have my PAP who is always in AFib, though it's controlled. I think his heart rate's between 65 and 85 normally. He takes Coumadin to prevent his blood from getting viscous and clotting. Because his atria are quivering, what can happen is a clot can go up into the carotids and you can have a stroke from AFib if your patient is not on anticoagulation therapy. Treatments for that include controlling your rate. So if you have a patient with a heart rate of 140, it's important to get that rate down to a more controlled level, less than 100 beats per minute. Antiarrhythmic medications such as amiodarone. So I know in clinical we talked briefly about amio. What we do if you have a patient that goes into AFib, let's say their heart rate's 150, you can bolus them with 150 milligrams of amiodarone and then start a continuous infusion at 1 milligram per minute. And this hopefully will convert them back into a normal sinus rhythm. Something to think about is amio can be given IV and PO, so you might see patients with chronic AFib that take amiodarone pills at home as well. It's also important, like I mentioned in the previous slide, to make sure that your patient may be anticoagulated if it's indicated, if they're, if that's something that they're allowed to be, to prevent thromboembolism. Also, if your patient is extremely unstable with AFib, cardioversion may be indicated. So that's when you hook them up to the defibrillator, you synchronize their R to R, and then you'll shock their heart out of that rhythm. Usually that's done with patients who are not hemodynamically stable in AFib. Again, I'm just trying to relate it to something that I know my PAP, who has a good blood pressure and has a fine heart rate, just happens to be in AFib, doesn't need cardioverted because he's hemodynamically stable. But you might have somebody in AFib that's with a heart rate of 150 and their pressure might be 60/20. So cardioversion would be indicated for that patient. Okay, so that was the atrial dysrhythmias. I'm going to upload this one to YouTube and send it to you guys as well. So I just wanted to make these that way you could have them, like I said in my email, for your leisure over the weekend to kind of go over them. If there's anything else that you want me to go over, just let me know. And I can make a narrated PowerPoint, or we can do a Zoom meeting or Google Meets, I think it is, whatever you guys are comfortable with or happy with. I hope this helps. Let me know how I can improve upon this, or if there's something else you want to go over. Have a great weekend, guys. Bye.